And so I thought we'd hear a little bit from Robyn about how being pregnant affected her mental health and what she wished she knew and that her therapist knew looking backward on her experience with her twin girls.
Thank you so much. I was under the care of a psychiatrist during both my pregnancies. I have been diagnosed with bipolar disorder in my early 20s, had been in treatment since my teens for various angsty things. And at 19 weeks, I had a psychotic break. I really wish that I had gotten some more psychoeducation on the risks of me having a break with bipolar disorder. And again, I could do the therapist walk of shame here that I didn't know this being a therapist. And when I had my break, which ended up being in my OB's office, I had no idea what was going on with me. And I was scared out of my mind. And the OB sent me to labor and delivery, and labor and delivery sent me to the ER, and the ER doc didn't know what to do with me. And I was waxing and waning and figured out how to get my nurse manager, because I worked inpatient psych, and so they wanted to call psych. I'm like, you can't call psych. Like, that's where I frickin' work. So I'm calling my nurse manager to call my psychiatrist to call the ER doc. And so, I was highly resourced, and they still were escalating me in the ER because they didn't know what to do with me, and the nurses trying to comfort me by patting me. And I'm like, oh man, the paranoia is just increasing by the touch. And so really helpful language that I learned today. So I had symptom reduction, but absolutely not remission for the rest of my pregnancy. And so I got the best of both worlds, right? So I had medication and symptoms. So that wasn't really awesome. And I would say it waned by the end of the pregnancy. But looking back, I was thinking about it today. I think the sleep deprivation just set in, and so you don't even know. I could have been psychotic, but I was so tired I didn't even know. And then I had another break at 8 months, which was, I would say, brought on by some OCD symptoms, which I also have. And that is a really ugly story where I ended up needing hospitalization stay, and child welfare was called on me, and it was a big mess. Thanks.
So here we have somebody who was uniquely positioned to understand her own circumstances, and yet it was very challenging, and it was challenging to get healthcare professionals to know the right path for dealing with this. What would this mean for a population that doesn't have the resources that Robyn has? And to get some insights on that, I think we're going to turn to Diana, who's working with women who are incarcerated, and she has been talking and thinking a lot about the role of trauma in postpartum psychosis and infanticide, and just sort of the path of what's happening to these women who don't have that circle of support. So maybe tell us a little bit about that.
Well, I was, at the earlier panel, I was nodding my head because of things that Dr. Ippen said. First of all, about attachment and the significance of attachment as safety. I can tell you that I've been doing the expert witness work for over 15 years now. I've had somewhere between 60 and 65 cases. I had a woman who did not have a history of complex trauma. And I think if we're going to understand state of mind in the present, which is usually what I'm asked to do, we have to understand their beginnings, and we have to understand their story. And story begins. And know that our earliest experiences inform our thinking about ourselves. They inform our thinking about ourselves in relation to other people. They organize our behavior and our thoughts. And when you have never felt safe, how can you possibly ever feel safe? And so when you look at this particular population of women, you are sitting with women who have never had the experience of safety. And motherhood, as we know, revives all kinds of memories. And for women who experience trauma, those memories tend to be traumatic. And not only have I never seen a woman who didn't have a history of trauma, but I've also never sat with a woman who didn't have a history of PTSD. And what ends up happening is that the past and the present become fused. And in these extreme cases where we see infanticide, the past and the present have become so fused that they're absolutely indistinguishable from each other. And so the woman who is, and some of you may be familiar with the term altruistic filicide, where a woman takes the life of her child truly believing that it is in the best interest of that child. That's where the past and the present are totally fused. And what she is really responding to is not what is necessarily happening in the present, but what has happened in the past, but is resonating in her body as now.
And these women could easily be painted in a very unfortunate and negative light. What's happening in terms of both how they're being charged and whether there's been some understanding in the ways that we're seeing maybe in Illinois, and is that happening here in California, for example? And also, how are these cases being reported upon as well to add to this image of who these women are?
Right. Well, unfortunately, these women are demonized. We have not made any inroads in that regard. Most of these women, I've had cases all over the country, and most of these women are being charged with first-degree murder, which means it's considered a premeditated act, intentional murder. And many of these women are looking at sentences of 25 years to life. The last year I was on a couple of cases where there are 2 women who are actually sitting on death row, not here in California, but in another state. One of the things that I do think is changing slowly, not nearly quickly enough, is our understanding that we have to look at a woman's history and as really an integral part of her state of mind. And I'm a very big believer in telling the story. And if we can tell the truth, a woman's truth, if we can tell her story, in addition to talking about symptoms, but really understand her story, jurors get that. They understand that. And so trauma, more and more, kind of a trauma-informed perspective, I think has become more of a consideration, certainly in terms of mitigating sentences, if not the actual, guilty by reason of insanity, which is a very, very difficult thing to prove in this country. And the reason it's so difficult is because there is a mismatch, using that word, there is a mismatch between how the law thinks about insanity and how we in the mental health community think about insanity. And in the law, you are only considered criminally insane if you did not know what you were doing was wrong at the time of the commission of the act. Well, we know that if you are in a psychotic state, you can be doing the wrong thing, but for very right reasons in your own mind during that psychotic state.
Well, thank you. And let's kind of move over to Illinois and maybe, have cases come to trial now with this new law, and how is that working out?
So the law was just signed by Governor Rauner about 2 weeks ago, and it goes to take effect in June, and there will be a whole set of rules written about how to apply that law. So it hasn't taken effect yet, but it is novel in that it allows women, even who have been convicted of a felony during the first year postpartum in the past, to use the fact that they had a depression or a psychosis to appeal for a sentence reduction, and it allows women going forward to make a case that they were suffering from a severe mental illness as a mitigating factor. So it also provides definitions of what a postpartum, they call it postpartum, but they refer to it as perinatal in the bill. So what is a perinatal disorder? And it is depression, anxiety, psychosis that interferes with function in the first 12 months after birth and during pregnancy. So it's for the first time some clarification in the legal world about what we're talking about. I think it's probably is happening in Illinois because Illinois is one of the states that has mandatory screening, but also because the governor's wife happens to run a mother-baby program for postpartum visiting in Illinois, and she gets it.
And one other question for you, Kathy, because we've been painting a bit of a bleak picture here about, you know, what's happening with the women in jails and so on, and what happened to you. But you have developed, in a way, something that seems so simple that it makes me wonder why people haven't thought about it, that's a routine part of your screening practice for women who might come in for depression, and that has been instrumental in really saving some lives. Could you talk us through that?
Yeah, I'll start with a sad part first. So I moved from Pittsburgh to Chicago about 5.5 years ago, and that big screening program that I told you about collapsed after I left. And there were over the next several years, there were 3 fairly high-profile maternal postpartum suicides, which just really broke my heart. At any rate, there was a lawsuit for one. Those funds are being used now to start an intensive outpatient program. There's already an existing outpatient program with perinatal specialists, to which I still consult, and they are forming, and will have probably in about 6 months, a mother-baby unit in which it is a true mother-baby unit with overnight children staying for the first time in America, all because of, wonderful movement forward, but did the tragedies have to happen? You know, that's the sad part. And in Illinois, we have perinatal screening, and we have a collaborative care program so that we have psychiatric services embedded right in our obstetrical program, and we have 13,000 deliveries a year. So we have a real active, combined, perinatal, obstetrical and depression program with a lot of training for our OBs. It took a long time to get that, and we're still working on some of the cultural, do we need to treat this from the OBs? But it's improving rapidly, and again, we're happy to think and believe that we've prevented some tragedies.
And Jonathan, before we open it up to questions, I feel like you're in this solutions moving forward framework for us too, to really talk about how some of these best practices can become integrated into a interdisciplinary pediatric setting. So maybe walk us through that a little bit.
Sure. So in line with the Healthy Steps model that I mentioned, and there are other models looking at this, we know that we can add professionals with the training around trauma-informed care, maternal mental health needs, and the infant and early childhood mental health needs that we discussed into a primary care practice. And the literature is absolutely conclusive that that leads to better outcomes for the child's development, for the parents' parenting practices in terms of safety, in terms of the serve and return, the type of nurturing parenting we want for early brain building, in terms of the satisfaction of the providers, which is interesting because if those of you are familiar with the healthcare quality improvement quadruple aim, it used to be called the triple aim, and then somebody realized you can't really improve the population's health unless you address the burnout of all the professionals in the clinical setting. And so Healthy Steps as a model really meets all of the aims of healthcare for quality improvement, and we're able to integrate these professionals. We have a story, encourage everyone to go on our website, very powerful story on healthysteps.org. At the bottom of the homepage, you'll see it, of a mother named Brittany, who was told that she would lose her life or her pregnancy, either one, and she could choose when she was pregnant because she had a problem with her uterus. And she said to her physicians, in spite of being a victim of maltreatment or abuse as a child, she said, I'm having this baby. And she wanted better for her child. She wanted to create a better life. And then when the baby was born, she had these repetitive thoughts, we're not supposed to be here. Her uterus gave out on the cesarean section operating table, and they took it out. She received a blood transfusion and was sent home quite quickly. And after that extremely traumatic experience in her pregnancy, and then went home and started to have symptoms of mental health needs, and not surprisingly for those who kind of work in the infant and early childhood space, when one of the Healthy Steps specialists walks in the room, she said, I didn't know who she was, but man, she looked like an angel. And the ability of someone, and the primary care providers see it too, the ability of someone else to step in who has the training and the time where the mother is. Many women in America, let's not kid ourselves, don't go to their postpartum visit with their OBs, which is why it's so critical to get them there and to recognize that the first professional to see them after they have a birth and get sent home is most likely their pediatrician or their family practitioner. And therefore, when we can add professionals who can take that extra time to support those women, to ensure that all children and family members are screened for child development, maternal depression, and social needs, and ensure we're connecting them to resources effectively with really good care coordination and follow-through, that's the Healthy Steps model, and that's what we know works. And we really should be paying for it, because women like Brittany and children like Lake, hundreds of thousands of them across America, are doing so much better and having so many more positive outcomes and fulfilling lives because of these types of clinical models.
Thank you. I realized I did have one question before I open it up for you, Chandra, which is just speaking of how we move forward. You talked about some of the unique challenges for people who are coming from low-income families or people who are coming from other cultures where they feel very alienated here. Are there some resiliency models that you're working on to help those populations?
That's a really good question. I think, so we actually have been doing child-parent psychotherapy for the last 20 years, and we work with low-income families. And I think what we've seen is really it takes all of you. Is that many times it's somebody who is working with them in a daycare setting, or someone who's at a pediatric clinic, or somebody who is a home visitor who really notices that the dyad is struggling. And that then what we do is we partner. So we call this trauma-informed systems. It would also be depression-informed systems. But where we're partnering across multiple disciplines to really help people who wouldn't traditionally get these services really understand that they are there and that they're safe. And so I also used to work in Los Angeles. But it's really building a framework where you can really think about building bridges of understanding of what have you been through and how does it connect to how you're doing? What has your baby been going through, and how does it connect to how your baby's doing, and how can we support you? And so I think this is like a fundamental, so that's fundamental to child-parent psychotherapy, it's fundamental to Healthy Steps, it's fundamental to many different programs that, we're sort of coming together through teams to really develop plans that support these families. The other thing I wanted to say is that it is sort of critical that we start to think about universal preventive interventions. So that how do we give away the information that we have to families? Because I'm really passionate about this, I just want to say I started a Pinterest board for our child-parent psychotherapy. And if you do go to pinterest.com/CPP treatment, whenever I find a good resource that would be free, I put it up there. So for example, Chicago Safe Start did a wonderful series of videos right, related to domestic violence. They're all free. They're in English and Spanish. That's a great way to reach out to people, to really help them see. So even if they're not going to seek help, they can start to see how these things affect them and how they affect their families. My team, we worked on a series, a free disaster-related series. We're part of the National Child Traumatic Stress Network, so we took our federal dollars and we turned them into free storybooks. It's called the Trinket and Sam series. So we started with hurricanes, then tornadoes, then earthquakes, and recently fires. And so if you Google Trinket and Sam, you'll see all these free story series that you can download and that families can really use them. And what it is, what these stories teach families is kind of, when you go through these disasters, this is how it might affect kids, but through the guise of these two little mice who have these symptoms, and then really like how do the families help them? And so it's a coloring book, but it's also a way that parents can really, we call it normalizing, like normalizing the traumatic response, or normalizing like, this makes sense that you're doing this, and here's some way that that parents help. Does that make sense? And so I think more and more we're getting involved in more sort of population-based efforts, and then for those who really need it, that makes it so that they're more ready to receive the services because we're not so scary, if that makes sense.
Yeah, and I think one outcome perhaps of this gathering is to try and pull together those kind of best practices and examples, either through your Pinterest page or through the 2020 network. That's very powerful. So we're going to open this up to all of you. We don't have so much time, so I would ask to try and keep the questions focused, and if it's for a specific person, mention that. There's standing mics all over here, and I'll just maybe go, I guess there's two of them. We'll start on this side and then go to that side.
Hi, my name is Summer. This has actually been a burning question of mine for 5 years. This is not for one specific person, but I'm just curious as to everyone's point of view on this. My son is almost 5. I guess you can say he was colicky, but I don't even consider that a real thing. I am an analyst, and I tried to research everything I could find to see if this was something real. Literally, my son cried 90% of his waking hours for the first 4 months, and I thought I had postpartum depression, but I knew specifically the day that he stopped crying, I would be A-okay. So we went to the doctors. They said, try bouncing him, give him some soy milk, try white noise. Nothing stopped. And then I was in a support group. I didn't know who to talk to. I was actually on an online support group, and actually one of the girls in there wanted to commit suicide. It was really scary. It was just, you're in the moment and you're hungry and tired and you can't eat and you can't sleep and you don't know when your baby's gonna stop crying. And then on his 4th month doctor's appointment, he stopped crying, and I thought he was playing a joke on me because I was going to see the doctor. He was gonna make me look like I was lying. Then he never cried again, and I was completely fine. But I'm just wondering, what do they say to moms and parents now? Like, is this a physical thing, or are they not matching like I heard him say? Or is there any general consensus of why some babies just cry very heavily for the first few months of their life?
Okay, so first of all, I'm with you. My firstborn didn't stop crying for almost 6 months, and for some reason, when we went to the pediatrician, which is super embarrassing for me as a pediatrician, he stopped too. So that, babies are just smart like that, right? But hopefully, pediatricians have learned that parents, we like to say, are incredibly sensitive tools for any problem in their child. So if they say the baby has a fever, forget the thermometer, the baby has a fever. Colic is a very complicated thing because there's no universal definition of what it is. People know kind of the rule of threes. Baby cries for 3 hours a day, 3 days a week, 3 weeks, but there's no universal definition, so it's very hard to research. We know that there are things that can help with whatever person's definition you use, but many of them require a parent with incredible bandwidth and support systems, right? So that in the middle of the night, you hand it to the other parent, right? Or you call in the grandparents, and since we don't live in villages anymore, that might mean they have to travel an hour, in the case of my in-laws. So it can be very, very challenging. And when I was in training, we used to say that most research that looked into the reasons for colic really does not actually find an etiology, but in the cases where we do find them, they're often related to gastroenterological symptoms. So reflux in babies who are either overfed or are fed the right amount, but for some reason it comes up on them anyway, heartburn, right? And gas. And so babies, people who have children with colic will often describe them as gassy, farty little babies. So some of the interventions, in addition to the typical shushing, swaddling, and just playing music and white noise, some of the interventions that can be tried are working with early nutrition and feeding professionals, like lactation professionals, if a mother is breastfeeding, to assess whether there's something that can be done with the feeding to decrease reflux, gas, or overfeeding. Many mothers of infants with colic are overproducers, which means they have more milk supply in a given feeding than what the baby needs. So that might fill up the tummy too much. Maybe the latch can be fixed so less air enters the infant's mouth. And then holding the infant upright, smaller, more frequent meals, which of course drives a breastfeeding mother crazy, right? She's got to feed even more often. For those who've breastfed, you know how insane that feels. But there are things we know we can do, even if we can't entirely say, what exactly is this colic? But I think with much of what we're describing here, it's critical that we consistently and comprehensively assess how the parents are coping with that, because it is a known trigger for mental health disorders and, unfortunately, for negative outcomes for both the parents and the children.
So we have a question from Monterey County for Dr. Wisner. Can you talk a bit about the topic of depression in African American women? What have you seen and what concerns?
Yeah, it's a very good question, and I'm very fortunate to have 3 African American faculty in my group who have helped me understand about being very sensitive in my assessment and our assessment of patients. I also had a wonderful experience in Pittsburgh working directly with Healthy Start, in which we integrated a psychiatric clinic right into the home base for Healthy Start. And what I learned kind of shook my medical training and background, because the way I was approaching my initial work was around, depression as a diagnosis and various treatments in the way that I'd been trained. And so what I had to do with the Healthy Start group, which I really enjoyed, was rethink how I was talking about these illnesses. So remember I said major depression's a bad name? One of the social workers in the Healthy Start group said to me, all these symptoms you've described, that's really result of distress from stress, isn't it? Why don't we call it stress distress? So in that setting, that's what we began to call it. Instead of the mental health clinic, we called it the stress clinic. We got no referrals to the mental health clinic. The stress clinic was overbooked, because it's like you were saying, you can join around a common experience. And when we were talking about the various interventions, we used a recovery-based model. What did that individual, what was important to her or to the couple? What was important to them to work on? Not, okay, you have depression, this is what we're going to do, but what's important? They would say things like, I want to sleep better. I want to have fewer obsessional, things that were really important to their function. So it was a way of operating that was very different than the way I operate now in a more medical-based clinic. And I think, again, very helpful to join with people around what is their experience that they would like help with, and we are together as a team. So I worked with their Healthy Start case manager. We were together as a team rather than I'm some outside person who's going to come in and do something upon you. It was a really wonderful experience for me. So working with any woman, I think that's a really good approach, rather than the way we're sort of more medically trained, and when you get put into situations where you have very little time, we tend to revert to. So I would say working in a much more collaborative, interpersonal, respectful way and recognizing their needs and goals rather than imposing a diagnosis with a set prescription is how I operate more in the clinic now, particularly with people from different cultures. I think it's also important to be very respectful. So if I have someone, African Americans, I'm much more comfortable with because I'm more familiar. But if I have somebody from a different culture, I will often ask, help me understand, what does your belief system, your culture, what does that bring to the situation? Tell me about that. And I think we're talking about this at dinner, I think these cross-cultural elements or respect for one's ethnic, cultural background are incredibly important, because unless you give that person a sense that you're in there with them, rather than I'm doing something upon you, it just doesn't work well. And that, again, just to revert back to the question, is what working with a primarily African-American population and now with a diverse set of clinicians has brought me to a greater awareness of.
Hi, my question is related to, it's wonderful to hear all of the models of efficacy, and as a doctoral level provider, I'm aware of a lot of the research that's out there and has been out there for many years, but we're still not seeing the uptake in our system, in our healthcare system. And a lot of times it just really boils down to the bottom line. So you mentioned, Dr. Goldfinger, making the case or asking the question, what are you doing in your system of care to implement these models that we know are evidence-based? But a lot of times the sort of throwback answer is we can't financially support that right now, or what is the evidence that there is that long-term, cost savings? So I'm just curious if you have any particular studies or maybe landmark evidence that we could point to when we go to make the case to a new system, whether it's a healthcare plan or a new practice that we're trying to work with, to encourage them to look at that financial cost savings or the return on that investment to really try to move that needle in that direction.
Yeah, not off the top of my head, but and that's because there are many emerging cost-saving studies that differ across interventions. So you talk about the intervention of having an infant and early childhood mental health specialist or a perinatal or prenatal psychiatric center, right? It really depends on what you're pitching your CFO, right? Talking about the bottom line. And first advice I can give is it's critical to get to the right decision makers, right? Oftentimes we spend so long churning our wheels, getting up the chain, that it's hard. The second advice that we've found successful is find the champions who speak their language. Oftentimes we find these executives are physicians, but they're being pitched to people who don't speak doctor speak, or as I would say, their specific specialty doctor speak, and so it doesn't resonate. So even if you brought the studies, they'd be like, well, that's nice, but there might be some jargon their buddy might say, and be, oh, yeah, the light bulb goes off. And the other thing I think is consider whether your health system, in terms of modern healthcare financing, takes on financial risk for outcomes. Because in the previous way of financing healthcare, where our health systems were not financially on the hook, we could just spend for, whatever malpractice CYA reasons, or because we believe every CAT scan and MRI is worth it, right? There was no financial incentive. But now that a lot of healthcare systems are trying to take on financial risk for the patients' populations that they serve, you have a better in. But you really do need the data, and so I would encourage you to work with the national office, so the National Office of Healthy Steps for Integrated Early Childhood Behavioral Health is at 0 to 3, and we have a staff whose job it is to do those calculations and to come up with those studies for you. We can't expect every well-meaning champion or advocate in a health system to have an MBA or even to understand the crazy intricacies of healthcare financing. So work with those who are working on it, like those at Cigna, like those in the national offices of a lot of these models that are beginning to evolve these offices to include those professionals.